Well, good afternoon and welcome. I'm always interested in conferences, particularly health conferences, which is where we tend to see this expression, the lay sessions, notwithstanding the interesting choice of language. It always bemuses me that because sometimes we end up feeling like the people that are doing the hard stuff are the health professionals whose program is often separate. And yet, as we heard in the first session this morning, some 97% of care happens at home. So that's you, the lay people. And I'm sure, like me, everyone has already learnt something this morning, which enhances the health and well-being of your loved ones. So we're going to continue the theme of that, and yet we are going to transition into a session this afternoon with Dr. Felix. Say it for me.
Ratchen.
I can't roll my R's. I don't know about you, but I don't even know where to start that sound. It's like I needed to be born an Aussie because I just can't do that. Felix is the divisional head of paediatric respiratory medicine at the Hospital for Sick Children, which is in Toronto. He's an advocate of newborn screening and early intervention strategies, and certainly haven't we all seen the benefits of those in the last 15 to 20 odd years. He's dedicated to finding better treatment regimes to improve the patient, the child, the client, the person's outcomes through numerous research studies, and he leads and contributes to many of those. Felix is actively involved in the organisation of the international meetings, including the American Thoracic Society, the European Respiratory Society, and the North American Cystic Fibrosis Conference, and he provides editorial support to many of the journals in the field right across the area of genetics, cystic fibrosis, thoracic medicine, and the like. He was recently founded the Lancet Respiratory Medicine Journal. So we thank you and welcome you so much for sharing your experience and your expertise with us.
Well, thank you very much. So I will tell you a little bit about me, which is not in my bio, and then we can go about the talk. I've been working in the area of cystic fibrosis for more than half of my life, and since my hair are turning gray, that's been a long time. So I've been doing this for more than 25 years now, both in research and in clinical care. And I worked in different areas. I started working in Europe, mostly in Germany. I then went to Harvard in the US, then came back to Germany, and I'm now in Toronto. So I've been exposed to different settings, different healthcare systems. I don't know much about the healthcare system in New Zealand, but I'm sure there are some similarities to where we are at in Canada. So what I would like to do is to go through some of the new therapies, and I would like to make this interactive. So at any time point when you want to ask a question, please do so. I know that if you give a talk to parents and families, and I've done that a number of times, that there's a different level of understanding as to the details of the disease. So I try to balance that in providing some of the information in a way that I hope it's going to make it digestible. And I will leave enough time at the end so you can ask questions which can be related to the talk but do not have to be related to the talk. So if we talk about new therapies and what will change, let's first look at where we are at right now. And this is showing you lung function data for our country, for Canada, and for 2 different years. And you can see that the lower line is 1990 and the upper line is 2007. And what you can see is that at every level, at any age, lung function is better than it used to be in the past. And you can see that for different countries. You can also see that if you look, if you use an upper limit of normal of 80%, that the time point where half of the patients will go below this level is 28 years now in Canada. So that has changed quite dramatically, and also means that we need more sensitive tests to detect abnormalities. And I'll talk a little bit more about this tomorrow. But the other thing that has also changed that CF as a disease is more of an adult disease than a pediatric disease now. And you can see that here for Canada, that in 2007, more than 50%, 56% of the children, to be correct, were adult patients. And in our center in Toronto, we have about 250 plus pediatric patients and more than 400 adult patients in our center. So there's quite a bit of shift now of this being more of an adult disease with a wide spectrum, and you'll hear more about this during this meeting as well. And there are a number of things that have changed over the time, and since I come from Toronto, I have to mention this, and this is related to nutrition, and most of my talk will be related not to nutrition, but to lung disease. But in the past, doctors in Toronto made the observation that nutrition is really key for survival, and this was a comparison done about 20 plus years ago by Mary Corey at our center, looking at two similar-sized centers, Boston and Toronto, and you can see similar age at diagnosis, but the main difference at that point in time is that they used a low-fat diet in Boston, which was at that point in time used in most centers around the world, where the high-fat diet was used in Toronto. And you can see the weight was higher in Toronto, as was your median survival. And that has really changed the approach to nutrition around the world in cystic fibrosis. But interestingly enough, we still see a difference in life expectancy between Canada and the US. And we don't really understand what is driving that. And we need to learn more about this, because this can help us to better understand which factors we actually need to focus on in our treatment. So when I talk about new therapies for cystic fibrosis, I need to spend a minute or so to talk about how lung disease develops, because the different steps in what we call the pathophysiology, or the development of lung disease, are important for the different treatment strategies that we think about and that we have developed. We know that there's this underlying gene defect in cystic fibrosis that causes this problem with ion transport, and mainly chloride as a salt. And this then leads to not enough fluid being in the airways, which we call airway surface liquid depletion, but means really that the airways are dehydrated. And because of that, the mucus clearance doesn't work so well. Mucus is not being transported the way it should be. And then we have this problem here of mucus obstruction and inflammation, which we see in our patients. And if you think about treatment strategies, the classic treatment strategies are really focusing down here on those aspects, on targeting mucus obstruction by mucolytics or physiotherapy, and then to treat infection, which is a major part of therapy in cystic fibrosis, has been in the past and will be in the future. And then targeting inflammation as one of the problems, even though we are a bit less good in doing that, and I'll talk about this a little bit later on. So if you think about the new targets of therapy, they are higher up in the cascade in terms of where the problems evolve. So, ideally, we would fix the gene defect by doing gene therapy, and I will briefly talk about this. And then there's a lot of interest and a lot of research going in what we call CFTR pharmacotherapy, so drugs that target the underlying defect in cystic fibrosis. And you probably heard quite a bit about this, and I give you my perspective on this. Then there's the possibility of addressing the salt transport defect by increasing chloride secretion or decreasing the sodium absorption that happens in the airways. And there's some targets that are still being looked after. And I'll talk a little bit about studies that have been done in this area in the past. And then there's this whole issue of hydration therapy, so bringing more fluid into the water. And I'll talk a little bit about this in terms of as an early intervention strategy to be done in infants and young children. So this is an older slide of what we call the pipeline of CF drugs developed by the Cystic Fibrosis Foundation in the US. And you see it's a busy list. And by now, actually, it doesn't fit on one slide anymore, so I had to break it down into different slides. But you can see it's quite busy, and a lot of drugs that are being studied, a lot of interventions that are being studied in cystic fibrosis, which is good and tells you that there's lots going on. And we look at them in different phases down here. So those that haven't really made it into the clinic are actually not on that list anymore because it would be too busy. And then we have the different phases of the study that drug therapy goes through. It starts with phase 1, which is usually done in healthy individuals, so not in cystic fibrosis. Then phase 2, where you look at safety again, but in the specific disease, such as cystic fibrosis, usually in adults first, and also find the right dose for the medication. And then what we call the phase 3 study is the pivotal trial that really proves or does not prove that a certain drug is going to work in cystic fibrosis. And then once that has been accomplished and has been shown to be efficacious, it can be come to the market and become available to patients. And you can see the number of drugs that have made it to the stage where they're available to patients is still relatively limited compared to all the others that are being looked at in clinical studies. So why are we so interested in finding therapies that work early in this cascade of development of lung disease? Well, the idea is that if you have a good CFTR pharmacotherapy or a good drug that works against the CF defect, that all of the other therapies that are currently being thought of targeting all these other areas would not be necessary anymore. And that would only be feasible if you start this therapy right from the get-go, ideally in infants right after the diagnosis. But that would really be the hope, that we could find drugs that are so efficacious that all these other therapies are not going to be needed. Okay, so let's talk about these first steps first and go into gene therapy as the first step. Gene therapy is really the holy grail of cystic fibrosis, and the idea in the past was that you would have a one-hit event where you could treat patients with cystic fibrosis, cure the disease, and then get it over with. And this is my simple view of gene therapy on this next slide. So what you need to do is to get the gene into the cells, which is shown here. This is a cell after gene transfer, which has become a little bit bigger because the gene product is now in it. And then the next step that needs to be achieved is that the gene is also expressed, so that the cell is now able to have this protein which was previously not present. And that has been a bit of a challenge. It works very well in test tubes, and it's actually relatively easy to do in test tubes, but it doesn't work so well in patients. So why is that? Here are some of the problems with gene therapy that we encountered. The therapy that is most effective is using viruses as vectors. So viruses as a way of bringing the gene product into the cells. The problem with viruses is they're quite effective, and in a cell culture that works perfectly. But the effect doesn't last forever, and so you have to do it again. And in a patient, that means patients know that if they have been in contact with the virus, the immune system will react to it, and the next time you give the virus, it will not work as well. And that has been a problem with gene therapy as an intervention using viruses. So it's not very suitable for repeated dosing, which will be needed if gene therapy is effective. So non-viral vectors, which do not contain viruses, have been used. Unfortunately, they're not quite as effective. There's still one project going on in the UK, the UK gene therapy trial, with repeated doses of a liposomal vector, but the initial studies are not all that encouraging. And then there's the whole question of safety. This is a therapy which brings DNA into cells, and that could be associated with some side effects that we don't want to have. And the ones that we're really concerned about are these off-target effects. And what do we mean by that? Well, we've seen that in other diseases where gene therapy has been used. So, for instance, immunodeficiencies. where patients that were treated with gene therapy actually developed tumors and afterwards, such as leukemia, because of the fact that other genes were activated in the process. And we still have relatively limited knowledge how to do that, and because of that, there's some danger in using gene therapy, and currently it's probably not the area where most likely we will see the success in therapy in the future. So if we think about other forms of treating this, or drugs to treat the underlying problem, and we call this, again, CFTR pharmacotherapy, we need to know what's wrong in cystic fibrosis. And this is a simplified way of describing what's wrong in cystic fibrosis. So think about the CF as a problem with the pump. And the pump is what pumps salt from the inside of the cell to the outside of the cell. And there are different problems with the pump, and this shows you a zoom in into the airways where this pump is being located on the top of the cells on the airways. And there are basically two problems. Either the pump is not present, so there is no pump that can work, or the pump is present but does not work very well. So, in practical terms, you can use two different approaches to address that. So the first one is to try to get the pump to where it's supposed to be. We call this corrective therapy. So you correct the problem that has led to the fact that the pump doesn't make it to where it's supposed to be. And the second issue is to use what we call potentiators, so to activate those pumps to make them work better. We have been more successful in the second point here than in the first point to date, but we'll talk about this a little bit more. And then there's the option of activating another pump in those cells, because this is not the only chloride pump that is present in the cell. So there are other pumps that could potentially be used. And the nicety about this would be that it would be completely independent of genotype. So you could do this in every CF patient, regardless of the genotype. Unfortunately, so far, that has not been very successful. And if we look at the pipeline and look at those compounds that have not moved forward, there are two here, danufasol and moly 1901, which have been used to activate an alternative pump in the cell in cystic fibrosis. And in the test tube, it actually works very well. I was involved in both of these studies, and unfortunately, both of these compounds have not been successful. So when we look at danufasol, the initial study that was done in about 300 patients with cystic fibrosis in the United States and Canada, and it looked like after the end of treatment, which would be this time point here, before we go into this bluish phase, that lung function was better for patients that were treated with danufasol versus placebo. And it seemed like this would also be continued during the phase when patients were switched to therapy. But then when this study was repeated in a larger cohort of patients, and this was done in multiple countries, including Australia as well, and you can see there's no real difference between the two groups in lung function. And this has told us two things. One is, if we see some initial results, we really have to confirm them in order to make sure that what we think might work does actually work in cystic fibrosis. And the other thing is that because we've seen a number of failures now for approaches to target other ion channels in cystic fibrosis, it may be the case that fixing the chloride problem alone may not do the job in cystic fibrosis, that there are other functions of this channel that we don't completely understand yet. We do understand a few of those that we may have to target in order to be successful. So, but there's also the option that we can say that not every treatment that we will study in cystic fibrosis will work. And I come from a country where ice hockey is quite popular. I assume it's not their most favorite sport here in New Zealand. And this is one of our top ice hockey players, Wayne Gretzky, and you may have heard about him. And he used the term, you always miss 100% of the shots that you do not take. And that's also an approach that we need to use in cystic fibrosis research, because unless we try to find out whether a certain therapy will work, we will never learn. So let's look into some of those therapies where we've seen success. And the one that you all have heard about is the CFTR potentiator, ivacaftor or Kalydeco, in patients that carry the mutation G551D. Unfortunately, this mutation overall is rare in cystic fibrosis, so it's about 4% of the CF population with some regional differences. This was the way that this works. In this mutation, actually, there's a pump present at the surface of the cell, but it doesn't open very well. And this drug helps to open it up. And what we've seen in this study is impressive improvements in lung function, as you can see here, right after the patients were exposed to this drug. And I can tell you that this was a study, even though it was blinded, patients knew exactly whether they were receiving the drug or not because they felt very differently to before. And the other thing that we saw, this is given as a pill, is if we looked at sweat chloride as a measure that we used to diagnose cystic fibrosis, that patients that were treated with this drug had a rapid decline in sweat chloride concentration, actually below the threshold that we consider to be diagnostic for cystic fibrosis. Whether that means that it fixed their cystic fibrosis, that's probably not the case, but it certainly had some very dramatic effects. And it taught us an important lesson that this is doable and that we can target cystic fibrosis with drugs. But how about some of the other mutations that we think about? And I'll talk about this in a bit more detail tomorrow. And I'm just going to focus on delta F508 because that's by far the most common mutation in your area as well. And for that mutation, the approach is to use a combination of this potentiator plus a corrector, so plus a substance that will bring more of the channel to the surface of the cell where it's supposed to be. And in the test tube, that works very nicely. So this is the corrector, BX809, or now it's called Lumicaftor, which gives you some activity, some increase in activity. But then if you combine it with ivacaftor, with Kalydeco, you go up to a range of about 30 to 40%, which is expected to be a range where you see clinical efficacy. And yes, in clinical studies, we did see some positive effects. And this is a very complicated slide for the different doses of drug that were used in this study. And I'm not going to go into all the details. But the important thing is the way these studies were done is that you would give the corrector first and then the combination with the potentiator to see what the corrector alone would do to patients and then see what additional benefit you would see with the potentiator. And what was seen in these studies is shown on the next slide. This is the first phase, and this is the placebo group. Not much happened, and actually patients had a little bit of a decline. These are the intermediate dose groups. Not much of an effect initially with the monotherapy, but the combination therapy, you started to see some effects on lung function. And then for the highest dose, there was actually a decline initially with monotherapy. But then with combination therapy, there was an increase. And you can see that these increases are not in the same range as we have seen for ivacaftor or Kalydeco in patients with the G551D mutation. So it's not quite as impressive. But you see an effect, and this is now being studied in two large studies involving more than 1,000 CF patients worldwide. And there's a lot of interest in that. But we also have to caution that the expectations shouldn't be too high for this therapy. Because if you think about what will happen in the future, there are a couple of things that we need to keep in mind. So, and one of the things is that one corrector alone is unlikely to do the job in cystic fibrosis. We probably need multiple ones, which will make it very complicated to study that. And so delta F508 will need multiple correctors combined. And the required combination will vary between patients. It's not that we have one mixture that will work for every patient. And we already know that from some experiments. And so we will need ways to predict clinical response rather than to go by try and error and see what works in a given patient. And I'll talk a little bit about this tomorrow in terms of what we could do in the lab to do this. And the other aspect of it is that a medication access will become more and more of an issue because these drugs will come with a price tag. And we've seen that for ivacaftor in already. These are some of the publications where people talked about this. Personalized medicine, new cystic fibrosis drug offers hope at a price. And here I have a cost for the $64 million questions, whether the $64 million is actually the amount that is going to be accurate for a region. This was for the UK, is up for discussion. But we don't want to be in this situation where we have wonderful drugs, but we can't really give them to the patients. And then we have to think about these questions. Is placebo actually right for you? That's not what we want to have. We have to make sure that the patients will have access to these medications. And that will be a challenge in the future. So let's move away a little bit from therapies that target the underlying defect and talk a little bit about other approaches, because these other approaches are also important. And if you look at these increases in life expectancy that we've seen over time, they have mainly been achieved by targeting these other aspects of cystic fibrosis. And one of the important aspects is clearing mucus, and this is how it usually happens in the airways. And one of the ways that we can do this is to use therapies that hydrate the airways, hypertonic saline or bronchitol. And I'm not going to talk about mannitol and all that much, because that's you're quite familiar with that. And you're also quite familiar with hypertonic saline because it was actually developed in this area of the world, even though this concept of patients feeling better when they were exposed to hypertonic saline at the beach has been used for decades in Europe, where there are rehabilitation centers at the Northern Sea for patients with cystic fibrosis, even though at that point in time, people didn't really understand why this was helpful for patients. So, and the underlying concept of how this works is shown here, where you have the situation here on the left-hand side. This is the surface of the airways. This is the mucus, and this is this little fluid layer that helps to stabilize the mucus. And if you bring enough of an agent that can draw in water into the lower airways of patients, you could actually fix the underlying problem in cystic fibrosis. And some people have referred to this as the poor man's gene therapy. It may not be quite as effective, but it could certainly work. And ideally, if you want to do this, you would like to do this as early as possible. And that's something that we have tried to target in a study. And I give you the concept before I go into the study, and this is related to when should we initiate a therapy like that via aerosol in a patient with cystic fibrosis. And I give you an example of how aerosol is being distributed in somebody who has relatively normal lungs, a CF doctor, and this is actually myself. And you can see the aerosol goes into most areas of the lung in a relatively uniform fashion. On the other hand, this is the situation in a patient with cystic fibrosis, and you don't have to be an expert to see the difference, right? So there's very little going into the periphery of the lung. Most of it will be in the central airways, and a lot of it actually ends up in the stomach, which is shown down here as this area down here. So not very efficacious. So ideally, you want to do this before you have all these secondary changes. And this is why we thought about doing this in a study in babies and young children with cystic fibrosis. And this study was called ICIS, Inhaled Saline for Infant Studies. And we actually included both infants and preschool children in this study. It was done in the US and Canada in about 30 cystic fibrosis centers, comparing 12 months of therapy with hypertonic saline versus isotonic saline. And we looked mainly at the effect of chest infections, because that was the main difference that was found in older patients in the Australian study. So what did we see? First of all, this is how the study broke down. So we included more than 300 CF babies and young children, so a relatively large study. I'm not going to go into the details here. But this is what we saw in terms of chest infections. No difference in chest infections between patients that were treated with isotonic versus those with hypertonic saline. So you may argue that isotonic saline may actually have some effect as well. And that has certainly been raised as one of the questions. The other issue is that most of these infections in these young children are caused by viruses, and whatever you give will not prevent the viral infections per se. And we also did in subgroups of these children look at some functional tests. So one of them is baby lung function tests. Again, I'm not going to go into the details of how you do that, but it's basically a way of doing the same kind of lung function test in younger children. And in the older children, we always talk about FEV1 as the lung function test. In babies, we talk about FEV 0.5 because they exhale much quicker. So it's about half a second. And we did see that patients that were treated with hypertonic saline had better lung function at the end of the study at the beginning of the study. And in our center in Toronto, we also looked at another lung function test, which is based on looking at unevenness of ventilation in cystic fibrosis, because one of the problems that we're facing early in the disease process is that cystic fibrosis is not a uniform concept. It doesn't happen in a similar way in all areas of the lung, and it starts in some areas where the other areas are still completely fine. And one test to look at this is the lung clearance index. And we've shown that in a subgroup of infants and young children, we did see improvements in this parameter in patients treated with hypertonic saline. So what have we learned from this? Well, this was the first large study that we did in these young children to look at a chronic therapy that we could use. We learned that we should now know better how to assess efficacy, and that we should probably need to use those functional tests. And we will look at this in a follow-up study to really see whether we should use hypertonic saline as an early intervention strategy in these young children. So let me talk a little bit about infection, and I know that this is a quick run through many areas of cystic fibrosis, and I cannot cover all the aspects. But infection is certainly a major problem that we're facing, and you can see the pipeline for infection is rather large. So there are lots of drugs that are being tested in cystic fibrosis. And if we look at the spectrum of bacteria that we see, this has changed over time. So in the past, it was all Pseudomonas. Now we see that up to adulthood, the majority of patients actually do not have Pseudomonas. And why is that the case? This is why we have been very successful with early eradication therapy against Pseudomonas. And this therapy is now considered to be standard of care in all centers around the world. And now we know that we should do it. The question is, how should we best do it? And there are a number of studies that we've done recently that help us in clarifying that. This is one of them that I have done with centers in Europe, where we looked at 28 days versus 56 days of inhaled therapy alone against Pseudomonas using tobramycin. And you can see more than 90% of patients eradicated the organism, and even after 2 years, the majority of patients still were negative for Pseudomonas. So a relatively simple therapy, effective over a short period of time. And centers in the US have done a large study looking at the same question, comparing inhaled tobramycin to the combination with oral ciprofloxacin, or the other part of the study was to look at using this therapy only if the cultures are positive versus on a regular basis every 3 months. And they found the same thing, no differences between the groups. So what we learned from that is actually that we can use some analogies from other diseases, such as leukemia and Hodgkin, where we also know that success rates of initial regimens are quite high. And if we think about new strategies, they're unlikely to be more successful compared to what we have. So we need to focus on minimizing the burden for the patients as well as the toxicity. and then focus more on defining risk factors for failures and treat those patients more aggressively that failed therapy. So this is one of the areas where we might be able to back off a little bit in therapy. And we do have algorithms how best to do this. This was developed in the European Working Group, and we're not going to go through all these details on how this is being done, but we agree on an international basis on how to best use these intervention therapies to eradicate bacteria like Pseudomonas, and that has been very helpful. But how about those patients that have other infections? So if we look at antibiotic studies that are currently being done with inhaled antibiotics, they mainly focus on chronic Pseudomonas infection, which becomes less and less of a phenotype. And other bacteria become more and more prevalent, and we have to start thinking about doing studies for those as well. And if we compare current strategies to those that we've used in the past, if you use a new antibiotic, it usually looks better initially than other therapies that we've used in the past. And we've seen this in a number of studies. This is one study where we looked at where inhaled aztreonam was compared to inhaled tobramycin. And this is looking at patient symptoms. And you can see this is the aztreonam group, and this is the tobramycin group. Initially, there's a difference when patients were on the drug. When they were off the drug, there was no differences. But after 2 cycles, there's no difference anymore. So we have to think about what actually counts, this initial effect or the long-term effect. But the other message here is that what we need in the future is options, different options of different antibiotics that we can cycle in patients in order to be more efficacious. And there's lots that we have in the pipeline. There's tobramycin inhalation powder, which has already been licensed in many countries around the world. There's colistin as dry powder, inhaled levofloxacin, and so on, so on. I'm not going to go through all the details, but what will change in the future is that we have much more options in treating infection and cystic fibrosis, and this will be a good thing for our patients. And as part of that, we also have to consider how we can use these new therapies to decrease burden for patients. And a good example for that is the tobramycin powder solution, which is shown here. And this is the way this is being inhaled. Traditional way of inhaling antibiotics is by using nebulizer solutions, which take about 20 to 30 minutes, and then you have to clean the nebulizer. If you use these devices, you can put a capsule in it, and the whole procedure takes about 3 to 4 minutes, no cleaning involved, and this really cuts down burden for patients and family. And this is something that we need to think about, and this is certainly something that will change in the future as well in a positive way, that we have therapies that are being brought to the lower airways more effectively, thereby cutting down the burden to patients and families. So just at the end of my presentation, I'm going to briefly talk about inflammation. And again, the pipeline for inflammation is relatively long, but most of these drugs have not made it to the point where we are close to bringing it to the clinic. And in inflammation, we face a major issue in cystic fibrosis. So anti-inflammatory therapy works very well in other diseases. So for instance, if you have an inflamed joint, you have arthritis, you give an anti-inflammatory drug, the inflammation goes away. That works very nicely. In cystic fibrosis, the problem is we have bacteria in those airways. So if we give an effective anti-inflammatory therapy, the bacteria will grow more efficiently, and the infection becomes more of a problem, and we've seen that in a number of studies. So just targeting inflammation alone and the neutrophils that are involved is certainly a problem in cystic fibrosis. So we have to think about the bacteria, and we have to find the right balance on how to do that. And that certainly has been a challenge, and one of the reasons that so far anti-inflammatory therapy has not been that effective. And the best anti-inflammatory therapies are probably those that have a broader approach. Antibiotics for once, but also drugs such as DONAS alpha or pulmozyme. And this is a study that we've done about almost almost 10 years ago now, looking at the effect on DONase alpha pulmozyme on inflammation. And what we've seen in this study is shown here, that if we look at inflammation in the airways, shown as neutrophils or elastase, those patients in blue are patients that were not treated, and over time, and this is a 3-year period, there was an increase in inflammation over time, which reflects the natural history of the disease. But in patients that were treated, we did not see this increase. And this becomes important because ARREST-CF has recently shown that elastase in the airways is actually important for predicting patients that will develop bronchiectasis subsequently. So these non-specific therapies that we have available may be our best bet for anti-inflammatory therapy at the present time. So let's come back to the pipeline that I showed you in the beginning. And this is another way of looking at a pipeline. And you can see that the pipeline is still missing some pieces in order to be complete, to give us ideal therapy in the future. And we don't exactly know where it's going. But we certainly have made quite a bit of progress, and progress is being made on a continuous basis. And the way to look at it is not as a single line of one form of therapy. The way is really to look at multiple therapies that you look at in parallel. And this is not a very pretty picture, I must admit. But it reflects that what we will likely be seeing in cystic fibrosis is multiple therapies at the same time being administered to patients. But again, there are challenges with that. And one of the challenges is certainly the cost of all these medications that we will combine in the future. And another way to look at this is as a puzzle. So if we think about different aspects of therapy, infection, inflammation, targeting the underlying defect, then the way to put this all together is by having different therapies and different pieces of the puzzle that will then, in combination, result in a successful treatment approach. But one important aspect of that is also, if we do this, is we really have to work together as a CF community, not only as physicians, but also with families, because we cannot do all these studies without the help of all the families and patients. And we also need help from industry in terms of supporting us in these studies. So this only works in a teamwork approach. So I will stop here and just show you the members of my CF team. And I'm not on this picture because I had to give a talk again. That was at the North American CF meeting. And also to say thanks to some of the funding agency that supports our work. And as I mentioned in the beginning, I left enough time for you to ask questions. They can be related to the talk, but they don't have to. Thank you very much.
That was a fantastic talk. It was there was so much to take in, and all of it was so well summed up, especially in a lot of your slides. Is there any way to have access to those slides?
Yeah, I can do that.
Okay, how would we do that?
I don't know what the best forum is, but we will make sure that.
Okay, great, thank you.
I'm sure that we'll do that through the conference program. I should have introduced myself. I'm Michelle Adair from CF New South Wales, and I'm sure that both CF New Zealand and Australia will gratefully help distribute your materials.
I was just wondering if there was any update on the ARREST-CF trial into azithromycin for its anti-inflammatory type effect?
I can't give you, so did everybody hear the story? This is about azithromycin as an early intervention strategy for cystic fibrosis, which is currently being studied in Australia. So there is no update yet because the study is still ongoing. I will talk a little bit about the azithromycin tomorrow. One of the issues that we saw with the azithromycin in a study that we did a couple of years ago on mild patients with cystic fibrosis, which was actually the basis for the study that's happening in Australia now, is when we looked at the anti-inflammatory effects of azithromycin using some markers that we studied, we see that the effect is more pronounced early on than it's later. So one of the concerns might be over that the efficacy of this therapy may not last as long as we would like it to last. But we'll see to that. So as of yet, we have no data, and I probably shouldn't comment on that at all, because maybe it's going to be overwhelmingly successful.
One of the slides you put up earlier on was to do with the effectiveness of a combination treatment of VX-880 on homozygous F508 delta patients, and you said it wasn't terribly impressive. You didn't put up one, though, to show the effect on heterozygous patients. Is that because it was even less impressive? Or?
Yeah, unfortunately in this study there was no clear effect on patients that were heterozygous for delta F508. In a way, this is also a mixed bag, because the phenotype will be determined by the second mutation that they have. And for many of these patients, we don't even know what the functional consequence of these mutations is, which is one of the things that we need to tackle in the future as well, especially for these rarer mutations. And but there are ways to sort this out. We have just done this for a mutation that is prevalent in the Middle East, where there was no information whether what kind of functional consequences this mutation had, and in some countries in the Middle East, cost is not an issue, so drugs like avacaftor would be readily used if they know what the mutation is like. So I think that's also something that we need to tackle in the future, is to sort out the functional consequences of these rare mutations in a way that we can effectively do this for all our patients. But in the study that was done using this mixed bag approach, there was no clear effect. And I didn't want to say that there was no effect on this drug. So there was certainly some effect, and the lung function changes were in the positive direction, and so it warrants further study. But it certainly wasn't as effective as these other approach. But it's also something that we learned in test tubes as well, that we need to use different approaches of targeting this mutation. But that will be rather complex to do. So because if you think about combining 3, 4, 5 different drugs, how do you best study that in patients? But I'll talk a little bit more about this tomorrow. So I just want you to come back tomorrow.
For nebulizing hypertonic saline, I guess in your experience, when would you suggest is a good age from the start in a reasonably well CF child, in your opinion?
Well, it's a difficult one. So we've done a number of studies looking at this in patients with relatively mild disease. This was one of the ones that I showed you, but we also did another one in patients with normal lung function, showing that it improved their lung clearance. So it is difficult. It's still a question that we struggle with. We certainly, from the study that we've done, starting it in infants and young children, many of the families that were participating in the studies wanted to continue the inhalation, and still do, because they feel that it has been positive for the children. Even though based on the data that we have so far, we don't feel that we can make a general recommendation to say everybody should be on hypertonic saline. But we can certainly say that we have a considerable proportion of patients on hypertonic saline now because of that, because parents participated in that study and then wanted to continue, and they wouldn't continue if there wasn't a perceived benefit. Well, we started at 4 months, so really early. But not all of these patients started at early. So the study included patients between 4 months and younger than 6 years. So relatively early. And we did some studies before to show that it's safe to be used in these young babies and young children. So, which was another important piece of information that we needed to have before we moved forward with that.
Just one more question at the back.
Sorry, I just have a daughter in the class 3 that the Kalydeco was tested on. She doesn't have G551D, but she's in that class. Is there any other gene combinations that class, that drug's been tested on in that class?
Well, I mean, there's certainly studies going on now with the Kalydeco beyond G551D for other mutations in this class to see whether it could potentially be helpful. It's a bit difficult because some of these mutations are rare, and so one of the concepts that is being thought of is doing what we call N of 1 study, where you do a study in one individual. And the way you do this is that you give the medication at different time intervals in a blinded fashion and then look whether it actually makes a difference. So you can do this. It's not easy to do, but you can do this, and it might be the way in the future to study these rarer mutations and the efficacy of these drugs in these rarer mutations. But there's a pilot study for that going on in Denver right now to see whether this is going to be feasible, and we hope to get some data in the next 6 to 9 months, hopefully.